Good evening, everyone. I am Dr. Sushruth, MBBS MS General Surgery, and today we are going to discuss postoperative fluid management. A human body contains about 50 to 70% of total body water, which is divided into three compartments: the intercellular compartment, the intravascular compartment, and the interstitial compartment. The interstitial compartment contains about 50 to 70% of this water, intravascular only about 5 to 7%, while the intercellular contains 30 to 40% of this water. Now, coming to fluid losses in surgical patients, most likely in a surgical patient, we would be concerned with the blood loss in the setting of a trauma, during the operative procedure, or secondary to a disease process. Other than that, there are obviously GI losses. Due to the pathology, the patient may have vomiting, diarrhea, nasogastric suctioning losses in enteric fistulas, and losses through drains and Foleys. Other than that, there's also fluid shifts, which are very much common in either postoperative patients secondary to inflammation, infection, sepsis, postoperative complications, or secondary to burns or intestinal obstruction even. So in many of our postoperative cases, patients are given a lot of IV fluid infusions, especially due to the fear of hypotension, and these patients may be hypervolumic initially. But despite this overhydration, the patients tend to be hypovolumic when it comes to their intravascular compartment. This is usually secondary to an inflammatory response, which leads to third space losses due to increased permeability of the vasculature, thus increasing the fluid in the interstitial space. So, coming to estimation of fluid requirement, first of all, we need to check if the patients actually do need fluid requirement. For that, usually when it comes to our biochemical parameters, burn to creatinine ratio, which is blood urea nitrogen to creatinine ratio, if more than 20 is generally suggestive of a pre-renal event, assuming that the patients have a normal renal function in the preoperative period. Obviously, urine output still remains the best clinical parameter to judge for hypovolemia or shock per se. Obviously, a high output suggests that the body is trying to get rid of water, while a low output suggests that the body is trying to conserve it. So, using furosemide, or basically a loop diuretic, furosemide bolus usually acts at the distal Henle loop and stops it from reabsorbing water, thus increasing the urine output. So, other than obviously using furosemide bolus, we need to clinically assess the patient and check if the patient is actually having hypovolemia. In case of a hypovolemic case, a low urine output tends to improve after giving a fluid challenge, which is basically increasing the maintenance rate after giving about 300 to 500 ml bolus. Similarly, in case of a high urine output, one can consider decreasing the maintenance rate. So, how do you calculate this maintenance fluid? You take the daily fluid requirement, which is usually urine output and other losses, which is as we discussed, through the NG, through the drain, through the Foleys, and add about 500 to 700 ml for insensible water losses, which usually are not accounted for when it comes to these general fluid calculations for these patients. So, the maintenance fluid calculation usually follows the holiday cigar formula, which as shown in the slides is consisting of using 4 ml per kg per hour for the first 10 kgs of the patient, 2 ml per kg per hour for the next 10 kgs of the patient, and then 1 ml per kg per hour for every subsequent kilogram. So, for example, if it's a 45 kg patient, for the first 10 kgs we use 4 ml, which is 40 ml per hour. For the next 10 we use 2 ml, which is 20 ml per hour, and for the remaining we use 1 ml, that equates to 25, which equals to about 85 ml per hour. Another thing to consider is if the patient is having anasarca, which is severe generalized edema throughout the entire body, usually due to losses to the body's interstitial tissues, the patient may not be having a hypovolemic state. When considering giving fluid to these patients, considering their maintenance rates, considering giving a fluid challenge, we should always look at the patients clinically. Does the patient have anasarca? Because older patients with comorbidities like heart failure, or if the patient is in sepsis and the patient has anasarca, it may not equate to a hypovolemic state. Other clues may be a tachycardic state, where the causes may not just be hypovolemia but also pain, anxiety, or increased temperature by that. So what do you see in a clinical state? You check for the sunken orbit, you check for their tongue, mucous membranes, any signs of moisture, and obviously a strict recording of fluid losses is to be done. You need to check for urine output, vomiting, diarrhea, drain outputs, NG aspirations, Foley's output, and serum electrolyte estimations should also be done. POCUS, which as shown in the slides, the diagram A shows the A lines, which are the normal lung lines, which are horizontal. B diagram, which shows vertical B lines, which indicate edema and increased interstitial fluid. D, the asterisk marks, shows effusion above the diaphragm, which is marked by an arrow. Focus, which is focused cardiac ultrasound, can be done to look for left and right ventricular function and presence of any pericardial effusion, along with which you can also assess IVC, which is a direct indicator of the right atrial pressure, thus telling us about the venous return, intravascular volume of the patient. While assessing IVC usually collapses during the inspiration, and a diameter of less than 2.1 centimeter with a collapsibility of more than 50% suggests a normal right atrial pressure. But in cases of mechanically ventilated patients, a dilated IVC may be due to a positive pressure ventilation and may not collapse when it comes to inspiration. So, while assessing such patients, the clinical parameters should always be kept on top, and these things should always be used as an adjunct to them. Other than that, there is venous Doppler, wherein an IVC along with the hepatic vein can be seen when assessing them through the subxiphoid space. Alright, so as a junior resident or as a resident who is looking after the patients, who's trying to do POCUS, you need not focus or you need not spend so much time on deciphering the intricacies of a POCUS. But the basics of it are that as the severity of congestion increases, the vessels become more pulsatile, and there is a flow reversal. That is, the flow is below the baseline in the systole, with further elevations in the right atrial pressure. So now coming to the choice of fluid, whenever it is possible, start your patients on an oral route. So in cases you cannot start the patient on an oral route, you can always try a nasogastric or a nasojejunal tube in case there is no contraindications to such, and again give them a trial of enteric feeds. Electrolyte replacement is a very important topic, especially calculation of potassium and calcium, because potassium is a very commonly lost electrolyte and calcium is a very commonly neglected electrolyte. Potassium supplementation is to be done of about 1 millimole per kg per day, and calcium of about 5 per day. So the commonly used IV fluids are normal saline, lactated ringers or RL, and plasmolite, which is commonly seen in the OTs. So normal saline can lead to a hyperchloremic state, which can lead to hyperchloremic acidosis, as chloride and bicarbonate are usually in equilibrium, and increasing the levels of chloride can lead to a state of non-anion gap acidosis. Ideally, solutions resembling the plasma or the serum are optimal. For example, plasmolite or normosolar are quite resembling of the electrolytes in blood, though the commonly used normal saline and the ringer's lactate can be used in alternative, as we use in our institute, to provide resuscitation to these patients. Other options are colloid solutions. Colloid solutions include 20% albumin. They include modified gelatin based solutions like Volpex or hydroxyethyl starch. There's also a range of plasma expanders which can be used, which are slower to diffuse in the extravascular space and thus lead to an expansion of the intravascular space. But they have their own risks, like coagulopathy, and increase in the amount of renal failure if the patient has such in the beginning. Albumin was used a lot in the past for increasing intravascular volume per se, but recent evidence shows there is no such benefit of using albumin alone. And obviously, in cases of hemorrhage, blood always remains the best replacement fluid. So, in shorter operative procedures, wherein intestinal viscera is not much handled, IV maintenance fluid can be started for these patients to correct deficit due to the NPO state, and after about 4 to 8 hours, 4 to 6 hours, and oral intake can be restarted for these patients, provided there is obviously a optimal GI path for these patients, and least handling of these bowel is done, and there is little to no suspicion of ileus, no clinical suspicion such as abdominal distension, and the patient is comfortable without any vomiting. Now, patients with major surgeries where the intestinal viscera need rest or there is an anastomosis that is done, these patients may require postoperative fluids for some days. In such patients, once we ensure that there is normal bowel sounds and adequate bowel movements, an oral intake can be again restarted, and we can start them on oral sips followed by a semi-solid food and ultimately a normal diet. In general anesthesia, postoperative pain leads to increased secretion of ADH and aldosterone, and salt and water are retained by the kidneys, and to avoid overloading of either salt and water, the fluid are the fluid of choice should be low in sodium and of low total volume. So when should we use fluids containing salt on the first day? So these are used in special conditions where we are suspecting an elderly patient with salt losing nephropathy, or patients with simultaneous treatment on diuretics, mannitol, or to replace extra losses like the nasogastric aspirations and drainage tubes. And patients after major surgeries also require fluid containing salts, wherein intestinal and renal handling has been significant, and saline is transfused to replace all these third space losses. We usually avoid potassium on the first days, about 1 or 2 days of the surgery, till we're sure that the urine output is established and normal renal status is ensured. Potassium supplementation is usually not started. Postoperative tissue trauma can also lead to an increased amount of potassium from the intracellular to the extracellular compartment, which may cause hyperkalemia. Intraoperative and postoperative transfusion of stored or hemolyzed blood may also contain a large amount of potassium. And postoperatively, metabolic acidosis will shift intracellular potassium to an extracellular space. As the body itself has a large store of intracellular potassium, no replacement is usually required in the first 2 to 3 days, as the patient will not go into hypokalemia. So, in cases of additional losses which are significant, like prolonged vomiting, nasogastric suction, the ideal fluid remains normal saline. If urine output is adequate, potassium is added after the second day, and decision to add potassium in fluid therapy should be guided by the serum potassium estimates along with the bedside ECG monitoring. Fluid losses due to small bowel fistulas causing diarrhea. RL is ideal for the replacement, and blood losses, which are minor, are usually replaced with 3 times the volume of normal saline or Ringer's lactate, and for larger losses, replacement with the ideal solution, that is blood, should be considered. In routine, 500 ml of 5% dextrose will give about 100 calories, and higher concentrations of the glucose solutions will increase the calorie input but simultaneously cause diuresis and increased risk of thrombophlebitis. So, for routine surgeries, when post-op fluid therapy is limited for about 1 to 2 days, low calorie input poses no such problems for this patient. But a patient having diabetes, thyrotoxicosis, obesity, chronic malnutrition need careful monitoring of serum glucose. An adequate calorie requirement is to be monitored. Thank you.